Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today we are going to delve into the deadly Tailor's bunion.
Yeah, something that we see way too often, and we'll talk about all the treatment options, surgery, what we see, and what you can do for your Tailor's bunion. So
yeah, it's a pretty common problem.
Yeah, a lot more common than I'd like to admit, because it's not one of my favorite surgeries.
Well, it can be a little technically challenging if you're going to do an osteotomy because the bone is so small.
Yeah.
It's a very narrow surgical neck at that point, and so fixating that can be somewhat difficult. But you see this for a couple of different reasons. One of them is really a ductovarus fifth toe.
Yeah.
So the toe is angling towards the fourth toe and tucking under the fourth toe.
Yeah.
And that positional problem is making the fifth metatarsal head abnormally prominent.
Yeah.
That's one reason. And then the other reason would be the fourth and fifth metatarsals are splaying out.
Yeah.
And that's really a completely separate reason, because I've fixed these where you just fix the toe issue,
and that
ends up bringing the toe back just like a regular bunion on the other side. You fix the toe position and that prominence isn't nearly as big a deal. So you can maybe just take a little bit of bone off the side, remodel it, but then getting the toe out from under the fourth toe makes that less prominent. As the toe dislocates or subluxes, it's just making that normal looking bone more prominent.
Yeah.
Right. But then there are those that have that real splaying, and man, you're not going to get very far if you don't do the osteotomy.
Yeah. So, clinically, we see this bump. Patients come in, they're like, look, I got this bump on my foot. It bothers me. It's been there forever. Is it a tumor? Is it a growth? Can you lop it off? What can we do for this? Is there a cream or steroid or something that I can put on there, or injection?
And how often do you go into okay, this is a shoe gear issue until proven otherwise?
Oh, yeah, you'll see. I mean, that's my first treatment option.
Yeah.
Where are we? All right, so we do our exam, right? Most of the time, you'll see that little prominence there, obviously. It'll rub on the side of their shoe. And just like Dr. D said, narrow shoes, dress shoes, flats, those pointed loafers and whatnot, pointed shoes.
And this is not a female or a male problem. This is both men and women. Men's dress shoes can be just as problematic as women's dress shoes when it comes to any sort of mild deformity there.
You get these calluses sometimes because of the pressure from the way it rotates out. And obviously you're pinching that bone between that skin, that rock and that hard place type of situation. And sometimes that callus is the main concern.
Absolutely.
They'll be like, look, this hurts. Can you shave this down? Is there a cream I can put on this? What can we do to kind of alleviate some of this pain? So.
And you have to go into the understanding also with the patient about calluses. They don't just pop up out of nowhere. There's a specific mechanical reason why that callus is occurring in that place.
Yeah.
And you can offload it with orthotics, but paring it down, it's just going to come back. So if they're okay with doing the routine maintenance, they can find a rhythm with urea-based creams and a pumice stone or a petty egg. And they can manage it even with the plastizote inserts, but they have to be willing to do the work.
Yeah, if you don't take the pressure off of it, it's not going to get better.
Right.
I have had patients come in, be like, look, I went to a nail spa, the last doc or whatever, they shaved it down, and it just keeps on coming back. So whatever they're doing, it's not working.
No.
And then I'm like, well, that's maintenance. You're going to get that callus.
Right.
It's a pressure spot. The goal is to alleviate that pressure spot. Now, that callus debridement, yes, it'll buy you time, maybe a couple of weeks, couple of months, but there's a reason you're forming that callus. Right. So adjusting the shoes, adjusting the insoles, ideally, and then that urea type cream or ammonium lactate, lachydrin, that will help keep that at bay, and that'll buy you hopefully years before you ever have to do anything. Hopefully never, but
at some point, most people are looking for a definitive answer, and I think that's where the surgery can be definitive.
Yeah. So we do our exam, we see the callus, we look at x-rays, obviously we want to make sure we're not missing anything. And so Tailor's bunion, people, assume it's a bump, it's a growth, it's a tumor, can you, knock it down? But then I talk to them, look, it's an angulation or a deviation of that fifth metatarsal. It's literally just slightly rotating out. And sometimes it can rotate out like, splayed out like on an angle, and sometimes it'll rotate out transversely.
And can you show the condyle? I mean, when that thing rotates slightly, look at that bump.
That bump is prominent. I don't know if these images show it well, but it's like two knuckles on the end of your bone that you're walking on these prominences, which when they're flat, it's perfect,
no big deal.
But then when it rotates out, you're walking on that.
Now one's more prominent, and it's and it becomes you basically reduced the surface area of that prominence by half.
Yeah.
And so now you've got twice as much pressure being applied to a smaller area, hence the pinpoint nucleated callus.
Yeah. So as that bone angles out, it's also rotating out, and that's when you walk in that little prominence. And that's that little bump that you see on the side also.
That is classic.
So, we talk about the x-rays. There's two measurements that, we primarily look at is the IM angle, and then how much of a variance there is in that bowing of that fifth metatarsal. And that kind of drives, if we go in surgically, how much we can really do as far as that shift goes.
And so the IM is intermetatarsal angle. So it's literally the angle between those fourth and fifth metatarsals. And we use the same technique when we're looking at traditional bunions between the first and the second metatarsals. That intermetatarsal angle or IM angle is an important angle to, I think, quantify the severity of a bunion.
Yeah, and that dictates the type of procedures we can get away with.
Absolutely.
So conservatively, like Dr. D said, you can do shoe adjustments. I typically will say, the little silicone pads, if you can fit them into your shoe to offload, that's a nice little touch. But the biggest thing is a wide toe box.
Hopefully you don't have to cut them all out like that. That's classic.
I have seen patients do that.
I know.
More for bunions,
Yeah.
I've seen one or two do it for bunions, but not for like fifth.
And they're usually cutting out shoes that only come in a D width. So that's what people don't fully appreciate too, is that things like, I don't want to throw these manufacturers under the bus, but most of the manufacturers,
fashion sneakers,
they don't make them in anything but a D width. And folks like, and I'm going to highlight the good guys: Brooks, Asics, New Balance, Saucony or Saucony,
Hoka.
They offer multiple widths and multiple widths in each size, which requires a different last.
Yeah.
The last is the model they make the shoe on, and it's clearly more expensive for those companies to produce shoes in multiple widths for every size. But it is such a better way to fit shoes.
Yeah.
If you've got an E or a double E or a triple E foot and you're trying to squeeze it into a D, you're going to be miserable all day long. It doesn't matter what we do.
Yeah. So, another thing that you can look into is when you do buy your sneakers, make sure that material on the top is elastic or soft. A lot of people will get like, look, I got sneakers, but then they'll have like that band or strap that comes right across there, and then like the
or crisscrossing designs
and stuff
right over the bum.
Yes, it's soft on certain parts, but the part that's pushing against your bunion, if it's stiff, it's not going to alleviate that pain. Yeah. So simple things. And then like we talked about before, urea creams, paring down the callus, orthotics, especially if you're not looking to have surgery in the near future, a simple way to help alleviate that pressure. And then finally, we dive into our surgical options. So you've exhausted all your options, and I kind of went through basic surgery, what it was like 50, 60 years ago, and to what it is now. So you'll kind of see the progression, Dr. D.
Awesome.
So initially, people used to do a transverse cut, let it drift over into position, and it was let it float to where it wants to be.
Keep your fingers crossed.
Yeah. And obviously a high incidence of non-unions, that doesn't work out too well, because if you have too much motion, that bone's never going to solidify. So they started putting K-wires, which worked out well, but obviously with wires, you're not compressing, right? You're aligning. So there was a little bit of a risk, but it was better than it was. I think that's just simply the beauty of metatarsal fractures / osteotomies is in general they'll mostly heal, and they don't even have to be that well aligned. So I think back in the day you could get away with that, but today I think the expectations are much higher because we have better fixation. So much better. So next line of treatment was to go in and shift it over, transverse cut, let it slide over, and put that little screw, fixate it, and it worked out beautifully. I mean, this is still one of the most classic go-tos. It's not the standard of care, but it is probably more common than not. as far as treatment options. You kind of slide it over, that prominence you knock down, and you put a little screw across there, and it works beautifully. It's tried and true. And it gives you that compression. Obviously, a screw is going to pull those two bones into good apposition. All right, so this is your modified Austin, your chevron type of cut. You're literally scarfing that joint.
Yep. Mm-hmm.
Yeah. And this is the way I typically do it, if I can get away with it. It works out well. I make my long arm. I do a long arm as possibly
as far as you can go,
as much as you possibly can.
Because throwing 2 screws across this one, I think's clearly more beneficial. I think you're getting better fixation. 1 screw, and I've seen it
just rotates on that screw.
That's the center of rotation, and the thing will fall one way or the other. So
yeah. And the bone is really thin. It's really narrow. Excuse me. So you really want to get as much bone-to-bone apposition as you can when you do that osteotomy.
Right.
And it works out well. Honestly, patients do well. I put little 1.7 or 2.0 screws in there, and they're a little bit bigger than your glasses. They do beautiful. You slide that over, you knock off that bump, and then I typically, I'd say 70-80% of the time I'll do a fifth toe arthroplasty with mine also.
I think I would do it. I mean, I'm probably 95% of the time I'm doing it.
And that kind of helps that toe from when you shift it over, the initial toe pain that they're feeling, you get that into good position, and it does well. So you can kind of see here they slid it over, they did that little arthroplasty. When I say arthroplasty, you're literally taking that distal part of that 5th digit head and you're just knocking it down. You're taking that out so they have nice motion there again. There's no curved toe contracture, and it does well. All right, so we're working backwards now. So now you're coming back to those chevron type of cuts, the wedge type of cuts. Your goal with those is you're shifting that apex of deformity as far back so you can get as much correction with a smaller osteotomy.
So for like really severe intermetatarsal angles, this could be necessary. I don't think I've ever had to do one back there.
No, it's not my go-to either. Yeah. The risk with these is that they're inherently unstable.
Yeah, and you can't really weight bear these folks.
Yeah, that's the downside.
You'd have to put them in a cast, keep them off of it for 6 weeks. This becomes more of a hassle.
Yeah, I push my long arm chevron as hard as I possibly can.
Yeah.
But there are people that do these, and they do work out well when they do work. They do work very, very well. Don't knock it, but. Not my forte. There are people that do beautiful with these.
Yeah, it would have to be a really severe IM angle for me to consider that, and even then, you can get away with a lot more distally and allow the patient to weight bear on it.
Yeah, this is a distal chevron. I thought a distal closing wedge. I thought I'd throw that in there. People don't do this anymore, but this was a type of procedure that was very popular for a good, 10, 15 years.
Tension band wiring.
Yeah, you put that K-wire in there, you do that tension band wire, you pull that K-wire out, 4 to 6 weeks out, and all that's left is this little tiny, tiny wire that, patients don't feel. It was a nice procedure. The risk of that is you're kind of hoping that apex of that cut, that it doesn't break off, because then you rotate on that wire, and that leads to bigger problems.
Yeah, you don't want to lose your intact hinge.
The risk of doing a hinge at mid shaft is that there's not a lot of tissue holding it steady. So we do hinges, all the time. We do hinges for bunions and stuff. And where you're aiming that hinge, you're also pushing for that hinge to have like soft tissue. So I do my hinge at that base of that proximal phalanx, right, where you have a lot of soft tissue and ligaments there. So even if that broke, you'd have that ligamentous structure holding it steady, keeping it nice and stable. Right. When you do a hinge mid-shaft like this,
not much there.
Yeah, there's not a lot there. Yeah. So I thought I'd throw that in. I thought it was interesting. I came across. Minimally invasive. So this was very popular back, early 90s. It kind of fell out of favor, and now it's kind of fallen back into favor. So I started with the baseline minimally invasive type of procedures. Yep. People used to do the K-wires and what are those called? The Shannon burrs, and So
doing small incisions, doing osteotomies, and then again keeping your fingers crossed.
So I have done a couple of these, the K-wires and the screws. I don't know. I think it has its place. Not my comfort level. I think that a small 1 centimeter incision versus a 3/4 centimeter incision, it's not that much of a difference. And if you use plastics types closure, the incision heals up beautifully anyways. But the goal of this was a small stab incision, like about 1 centimeter. You go in, you use a small reciprocating saw, or a Shannon burr was the go-to, and it kind of goes through. You cut across, you wash out that area, you milk out all that bony debris, you kind of leave it a little bit in there because it kind of helps bridge. And then you put a wire, and the way you would do this is you'd run that wire from the inside out towards the tip of the toe. You'd run that wire in and out towards the tip of the toe, and then you'd slide that bone back over, and then you'd put that wire into the shaft of the fifth metatarsal. And the nice thing about this was, you have a small stab incision and a wire, and then no remaining hardware. So it was very popular. It did, pretty decent. But most of the studies showed that it was like 1 in 20 end up having like a non-union. The K-wires obviously aren't as stable, and
and you're using that K-wire just as a bolster.
Yeah,
it's really not fixation.
Oh no, it's not. It's because
it's like a bolster.
Yeah, there's nothing going through the distal fragment here.
And this is a tribute to the ability of metatarsal fractures to heal.
Yeah.
Pretty much in most cases, because you've got this tiny little bridge, and when you look at the final outcome, that looks.
This looks great.
This looks decent.
But you're kind of hoping that this little portion here touching.
Yeah. How many of them ended up in non-unions?
Yeah, I was looking through the studies. It's about 1 in 20. It was like 95%. I mean, that's not a good statistic as far as something I'd like to risk. And obviously, that's what was documented. You know?
So that's, what does that equate to be? 5% non-union rate. That's higher than I'd like.
Yeah. And that's, like I said, that's what's documented. So this is the newer style of minimally invasive type of fixation. I've done this style. Like I said, it's not my favorite. Small incision. The nice thing about this is they come with little jigs that help you direct and point that fixation for that screw. You get compression across that fixation site. There's a bunch of companies that are making plates now that you can impact into the shaft of the metatarsal. They do well. I haven't seen too much studies on this stuff yet. It's still fairly new. I'd say less than 5-10 years,
So you're sliding that plate into
the shaft,
into the medullary canal.
Exactly.
Interesting. I can't say I have any experience with that. That looks like it would be pretty stable. Yeah,
it's inherently stable. You can get good compression across there. But still, like I said, I haven't seen the studies on this. And the incision 1 centimeter versus 3 centimeters. I mean,
how much are you gaining?
Yeah.
In fiddle factor, losing in fiddle factor. Yeah, I don't know. I'm certainly not gonna poo-poo it because I have not tried it.
Yeah, I can't say anything bad about it because I know people that do this and they swear by it. Just not my forte, honestly. If you want to do minimally invasive, you can find people that do minimally invasive. I do certain procedures minimally invasive, but for my my Tailor's bunions, not my go-to. But yeah, they do work. Recovery. So recovery is pretty straightforward. We're looking at a walking boot, depending on the type of procedure. If you're doing a proximal osteotomy type procedure, you're most likely going to be non-weight bearing. But for the vast majority of these, you'll be weight bearing. You can do surgical shoe or boot. I'm a boot guy. I think it just works beautifully. And rest, ice, elevate, and let that bone heal. Young adults, you're looking at 6 to 8 weeks in a boot most of the time, and back to normal shoes soon after.
Absolutely. Yeah, and it's all based on x-ray evidence that the bone's healing. So, I always like to say, this is all based on x-rays. I can give you an estimate. I can give you a ballpark number, but it's got to be based on real data. And the data we're looking for is trabecular bone crossing the osteotomy.
You want that bridging coming across there.
Right.
And once you kind of start seeing that, you're golden. It's like any other type of osteotomy. You want that to heal, and I'm not trying to risk anyone's foot. So,
excellent, very good. Well, that was a really awesome overview of the dreaded Tailor's bunion.
Yeah.
But these are common problems. They have reasonable success with conservative non-surgical options, but you have to be willing to adjust your shoes.
That's the hard part.
Yeah.
A lot of people want to wear their dress shoes. I have to wear dress shoes to work. I'm like, you're going to have to buy wider shoes. I tell patients, go buy Dockers. They're typically round, and they're wider. If you get like the fancy pointed shoes, you're
if with this foot structure, you're asking for trouble. Yeah. For sure. So you feel for the folks that have that forefoot deformity and have to wear dress shoes to work. That can be difficult. But just know you've got a potential surgical option that has really, I think, excellent outcomes. Yeah. And we have a number of different ways we can fixate it. But the vast majority of them allow you to weight bear after the surgery, so that's great.
Yeah.
Very infrequently would they require a cast or non-weight bearing. So pretty awesome. Excellent. All right, Dr. Hussain, thank you very much for the overview on Tailor's bunions. We'll have to get maybe a surgical video on one of those up soon.
Yeah, I'll pick out one of mine. We'll get it on here.
Excellent. All right. We will see you guys next time on the Pod Doctors.